we go.
Oh, all right. Great. So you guys are like the first group of people that are going to get this longer version of this presentation that I'm going to give at the Perform Better in America in a few weeks. So I did an abbreviated version of this at the winter seminar in Boston here. And I'm happy I get to kind of expand on that idea with you guys for a full hour here. So what I want to do in this presentation is give strength and conditioning coaches, fitness professionals, a guide to working with clients and athletes who are working through a rehab process. I think often it can be very daunting for the fitness professional to take on a client with an injury or take on a client that's coming out of surgery. And they often feel like they don't know where to start. They might be in over their head and they're not qualified to deal with working with someone in pain or someone coming off an acute injury. And I'm here to tell you all that you 100% have a part in the rehabilitation process as a fitness professional. You are as much as a part of that team as the doctor. You are as much as a part of that team as a physical therapist. And what I want to do is try to teach you how to do your job most effectively and work, and most importantly, as a team with those other professionals that I've mentioned. And so as we go through this, I'm going to try to go step by step to try to teach you how you can make an impact. I find when speaking to a lot of our staff, our interns, our younger staff, the people we teach at CFSC events, they tend to display the symptoms of what I would call imposter syndrome when dealing with people in rehab situations, meaning they feel like, I don't know what I'm doing, or I'm in over my head, or I'm not qualified, because I think sometimes you can be intimidated by the fact that someone has this serious injury. So the consequences in your mind are a lot heavier. How can I ensure that this person doesn't get re-injured? How can I ensure that they get to where they need to go, 12, 16, 18, 20 weeks from now? How can I make sure that they have the outcome that they want? And those consequences can weigh heavy on a fitness professional if they're starting to deal with something that they haven't worked with before, like an ACL injury or an Achilles tear or something like that. But you already have the skills. Very likely, if you've been through the CFSC course, if you're following the education that Felix is putting out, if you're attending these webinars, you very likely have the skills to work with someone coming out of any of these, seemingly complicated rehab situations. You just might not know it yet. And that's what I want to try to shine the light on here today. Often, for both you and the athlete, when you're working through these rehab processes, they're usually marred by confusion and fear, and sometimes setbacks, which can be intimidating for you, and they can make you question your process as a professional, and they can sometimes bring about anxiety and self-doubt in the athlete or client that you're working with. But if you stay focused on your principles and the things that really guide training, even with healthy individuals, then those are going to be the things that get you through that process, right? So I would say your principles are like your lighthouse out in the distance. And if you just stick to those things, the basic things you've learned when you were learning how to be a good personal trainer, a good strength and conditioning coach, those things will pull you through any rehab process. And I think often when we get intimidated, we tend to forget our principles as trainers. And so that's going to be the number one thing we really want to focus on, is going back to having a solid set of training principles of progression and progressive loading and communication that are going to help pull us through. So the 4 questions that I'm going to try to answer today are this. Number 1, where do I fit in the rehab process? As a fitness professional, what is my role? How do I interact with the medical professional, the physical therapist, the sport coach, the parents, the athlete themselves? Number 2, how can I help? What is my role on that team, right? Am I a star player or am I an assistant? What is my process that I'm going to impart on that athlete to help improve the outcome? Where do we start? Where am I appropriately starting on that timeline? How should I begin with someone right after surgery? And then finally, how do we progress to ensure that they get to where they need to go in a timely manner and in a safe manner? Okay, so I think if we can answer these questions, it's going to give a lot of people a lot more confidence to work as a fitness professional in the rehabilitation space. So number 1 we're going to answer is, where do I fit? As a rehab team, where does that personal trainer, strength and conditioning coach, where do they fit in that whole process? And realize it needs to be a client-centered approach, right? There should be a doctor involved. There should be a physical therapist involved. There should be a sport coach involved. The parents should be involved in the process if it's a kid, and then yourself, right? And we all need to play our role at different times, right? But at the end of the day, the star of this whole cast is going to be the athlete or the client. It's not you, it's not the doctor, it's not the PT. None of those people are in charge. The client is in charge, and we are all inputting our own little piece of the performance to try to lift that person up. It's not about us. And so number one thing you tend to need to find is you need to put your ego to the side. I think often you see the professionals in the process battling with each other and losing sight of who we are actually trying to help, and that's the client, right? So if you are somebody who is working in the rehab space or is planning to work in the rehab space, the way I tend to recommend people to ensure success early on is proactively go out and build your own team, right? So I would say go find orthopedic surgeons and doctors who think strength conditioning is valuable, right? Who have the same thought process as you. Go find physical therapists who also think strength conditioning is valuable. Go find physical therapists who you think do a good job. Align yourself closely with sporting organizations and coaches who value what you do as a strength and conditioning coach. If you can build your own team proactively, then when a client comes in injured, either referred from the doctor or someone who reaches out to you, you have all the resources available for them, and everybody there will already be on the same page. It's much more difficult to get a client and then try to build those relationships with those other professionals afterwards. If you can start to build those relationships beforehand, one, you're going to have more business than you can ever handle. But two, the client is going to be in the best situation possible when all of this is over. So I always say, go out and build a team, actively try to get referrals and send referrals to other professionals, and then you will be in the best place to serve that client because your professional relationships will already be established. Okay. Realize on this timeline, the fitness professional isn't going to be the first person out the gate, and that's okay. It's usually best for us to hang back and wait till it's time to play our own role. If we're coming straight out of surgery or from an acute injury, the doctor has to be the first person to see. They're there for triage. They're there for immediate injury. They're there to evaluate when someone's ready to go to physical therapy. Those aren't things that we are specialized to do as fitness professionals, and that's perfectly fine. They are going to be better served to handle those tasks, just like you would be better served to teach someone how to squat, right? I wouldn't send them to a doctor to do that. Then we still want them to go to a physical therapist. Although there might be some overlap in what we do as a fitness professional with a physical therapist, the physical therapist is going to have early stages of rehab, normalization of passive ranges of motion, early resiliency training, and then eventually they're going to start to progress towards us. And the benefit of being a fitness professional is although you see them last in the process, you're probably going to work with that client longer and more frequently than any of these other professionals, right? With a fitness professional, you might, as a client, be working with someone multiple times per week for years, indefinitely, right? Whereas with a physical therapist or a doctor, it's usually a short and finite timeline. So we want to take advantage of that, but it's best that we wait until they go through the proper steps to get here. Don't be eager to be the first person they see. Let them come to you and work closely with the doctor and the PT who is there before you, okay? And I think it's important to kind of think about these definitions between coach and physical therapist, because now more than ever in our field, we're seeing more and more overlap between strength conditioning and physical therapy. And I really think that's great. It's great for strength and conditioning coaches to learn more about physical therapy and learn some of those techniques. It's great for physical therapists to start to invest in learning about fitness and building resiliency. And I think there can be some overlap in practice, but we have to realize that we should stay in our own lane. It's best for us and it's best for the client. Don't try to be something that you're not. Let the physical therapist be a great physical therapist. Let the strength coach be a great strength coach, right? Physical therapists diagnose injuries. They might even see someone before a doctor sometimes, if you're in a direct access state where people can go straight to a physical therapist. Coaches do assessments. Physical therapists look at injuries and say, hey, this is an ACL tear or this is a hamstring strain. Coaches assess everything else. If someone comes in with an ACL, a diagnosed ACL injury, to me as a coach, I'm going to assess their quad strength. I'm going to assess their hamstring strength. I'm going to assess their hip mobility. I'm going to assess their core strength. I'm assessing everything away from that injury that can improve the outcome of that injury. whereas the physical therapist diagnoses and zeroes in on the injury itself, right? So we're going to look at the environment surrounding it. The physical therapist is going to be look at the injury that's we're specifically treating. Physical therapists provide treatment, right? They're going to work on pain management. They're going to work on passive range of motion. They're going to work on early strength development. Whereas we're working on training. We're looking about increasing overall capacity. They're getting that client back to baseline, right? So they're handing us off that physical therapist that physical therapist handing us off the client once they pretty much reach baseline. And then the physical therapist is providing a prescription, okay? Whether that is an actual prescription for pain management or whether that is rehab exercises. As a coach, we're providing guidance and empowerment and starting to teach these clients how to manage themselves, hopefully, right? So although there's some overlap between these two things, we are much more facilitators, where physical therapists are typically directly managing that pain or that injury that they're coming to see us for. And we want to make sure we differentiate between those and make sure we're working closely with a physical therapist so we can defer to them when that's necessary. Realize though, our arena as a trainer is much bigger than a lot of us realize. I think sometimes we just think about like, oh, we're just going to get that, hamstring stronger, or we're going to get that knee stronger after that ACL injury. It's not, it's much bigger than that. I think often when athletes come to see us, the number one thing we're doing is providing social support, and we're promoting self-efficacy, and we're trying to get them to feel empowered that they can come back from that injury. Because we know often when athletes come to see us, they have a pretty negative outlook often on their injury, especially if it just happened recently. Typically, we want to open up their eyes to try to think of that injury as just a small part of who they are as an athlete. So if you look in the top left, that the two circles where it says athlete, it says injury. Typically when athletes come to see us, they're seeing the opposite of that. All they're thinking about is that ACL tear. All they're thinking about is that shoulder injury. We want them to realize they can train the rest of their body regularly and still train like an athlete. And then over time, we're going to bring that injured segment back. And then on the right, where you see this picture of the tree, I often say in the fitness space, we're often dealing with what I call low-hanging fruit, things that these clients know they need, but our job is to facilitate them and empower them to do these things. So we're improving overall movement quality. We're improving strength and power. We're improving aerobic health. We're providing them social support. I would imagine most of you know this. If you're actively training people, half of your session is usually working more as a psychological therapist than a physical therapist or a trainer, right? We're talking to them and working them through these things and some of these barriers they might have in their head, not just that they're dealing with physically. And then we're also promoting their self-efficacy and autonomy. We want them to feel like they are in control of their situation, because very often people who are injured feel like they've lost control of their health. And this is something that, due to our frequency that we're seeing our clients multiple times a week, we can develop these relationships where physical therapists and doctors might not necessarily be able to do that. Okay, so although that was kind of big picture, now we're going to talk specifically, how can I help? What are the tools that we have as trainers in our toolbox that we can specifically help the healing process and help the rehabilitation process? So this is a graphic that I got from a great strength and conditioning coach named Patrick Ward. Probably back in 2012, I did a seminar with him, and he talked about this idea of the buffer zone, the physiological buffer zone. And essentially what we're saying is that with our clients and with our athletes, the number one thing we're trying to do is increase the size of this buffer zone. So we're trying to increase the space between physical capacity and breakdown and injury and pain, right? We're trying to make our clients more resilient to stress so that they don't return to injury, they don't break down, they don't get hurt, okay? And typically when our clients are coming to see us in a rehab situation, this space, this buffer zone that you see in the middle of the page is really small, right? It doesn't take a lot for them to have a relapse and get re-injured. It doesn't take a lot to flare up that injury. We want to try to make them as resilient as possible. That's what we do as strength and conditioning coaches. We build resiliency, right? And in looking at all the athletes I've worked with over my career, there's three things I can really put my finger on that really durable and resilient athletes demonstrate, right? They have high quality of movement. Their joints move well. They have great tissue extensibility. They have great joint mobility. They have high levels of fitness, and they have high levels of resistance to stress. If we can work on improving these three qualities, typically you're not going to see people get re-injured. You're going to see successful rehab outcomes, and we're going to see high levels of performance, right? And not every athlete that comes to you is going to have these things. We might need to work on, different parts of this triangle to different degrees, right? You might have an athlete who moves very well. They have great mobility, but they're very weak. So maybe we have to work on developing higher levels of fitness. Or maybe you have someone who is very fit, but they have poor quality of movement. So we need to work on their joint mobility, okay? Or maybe they have high resistance to stress, but they don't have very high levels of fitness. So you might have to invest different amounts of time, and we're going to talk about assessing for these three things later on. But generally, I think if you can address these things, we increase their buffer zone, we increase their resiliency to stress, okay? It's important to realize that just the act of exercise promotes a healing environment for someone who's going through a rehab process, right? So say that I had an ACL surgery and that ligament in my knee has to heal and the trauma around my knee has to heal. Just the act of exercising away from that injured segment, developing my aerobic health by riding a bike maybe on one leg, strength training on those other limbs, and promotes an internal healing environment in my body. It increases levels of growth hormone, it increases dopamine and motivation, it increases blood flow through the joint in question, even if I'm training away from that joint. All of that is encouraging healing, even without you addressing the injured segment. So I always tell to my trainers that work here that if you feel intimidated by the fact that someone has some sort of injury, realize you probably don't even necessarily need to train that segment for a little while. Let the physical therapist work on that, and you work on developing fitness everywhere else in that person. And that is going to improve their outcomes in physical therapy because of all the good things that are happening in the internal environment of the body that go with exercise, right? When we're training, we're promoting and growth and improvement in their physiological system. And that is globally going to have a positive effect on whatever they are rehabbing at that time, okay? But what are the things that you can definitely do as a trainer to help improve that? Number one thing, we talked about movement quality. These are things that are in your wheelhouse as a trainer. Working on their respiration strategy so that they're more efficient. They're going to help them be more aerobically fit. It's going to reduce the amount of compensatory strategies they use to move if we get their rib cage and their pelvis in a better position. Working on tissue extensibility and joint health. All of these things are things we can address, right? So are you foam rolling with them every day, right? If someone's coming out of a lumbar rehab, a low back rehab where they had back surgery, by spending time foam rolling their hips, spending time foam rolling their quads, you're creating more usable motion in their hips so that there's less compensatory stress on their spine. That is part of the rehab process, right? So someone fresh off lumbar surgery, you don't have to address their lumbar spine. Address everything around it. It's going to help them feel better and come out of that surgery quicker, right? Motor control and afferent feedback. So improving how all of their joints move. Again, not just foam rolling, but actively stretching and doing drills that are going to improve the proprioception in the surrounding joints. So like, say for instance, I had just had neck surgery or had a neck injury. By improving the feedback and mobility of that shoulder, like I am in this video, you're actually improving the overall mobility and afferent feedback in that upper quarter of their body. So me having to move my shoulder without moving my neck and moving my back, I'm not treating that neck directly, but I'm actually improving that shoulder mobility, which is going to help me not compensate at my cervical spine as much. So you want to always think, what can I do away from the point of injury that's going to help this person be better, okay? Also, you have to think, if you're working with athletes, often we want to think about sport-specific adaptations of mobility, right? What adjustments do I need to make for this athlete that is going to help them adapt specifically to their sport? So, I mean, I use baseball as an example because it's pretty common in America, but there's much bigger changes in their shoulders and their hips based on their sport that we need to take into account. If you're working with general population, I want to think about what we call life-specific range of motion. What are the things that they do every day? For example, I'm working with a gentleman now who had a shoulder replacement and neck surgery fairly recently. And he's someone who sits at his desk hunched over like this all day long, right? So I need to make him more resilient to be able to be at his desk. So we're working on improving his cervical range of motion. We're working on his shoulder range of motion, but we're also working on his hip and his lumbar range of motion because all those things get reduced from him being stuck at his desk. over the course of the day. So you want to take into that individual, like what demands do they need for their specific activities, whether that's sports or whether that is in everyday life. Moving along the spectrum, we want to start to think about developing dynamic movement skills, right? This is also something that's going to be in your wheelhouse as opposed to necessarily a doctor or physical therapist. Improving general coordination and balance. Okay, even if it's like away from the injury site, what we want to think is, how do we, like, if you have someone who's older, right, and they're coming from, we'll say, a hip injury, making them more confident to go out and walk every day and move freely and move dynamically is going to lower the chances of them re-injuring that segment later on. So we want to make sure, doing things like skipping, ladders, shuffling, moving forward, moving backward, improving their rate of force development, low-level plyometrics, okay? We know that when people can put more force on the ground and they can do so more rapidly, they're less likely to have trips, falls, increased risk of injury rate. And then we also want to teach them how to eccentrically accept force and dynamically produce force. So power is a big part of that rehab process. And that's going to be something they come to you for as opposed to necessarily going to their average doctor, their average physical therapist. So whether that means jumping over hurdles, like Lisa was coming back from a back injury, and this is something we worked back up to following her back pain. We started with, just jumping onto a box, working over the hurdles. And then eventually, introducing people to things like ladders. Okay, like I want people to be able to reclaim their dynamic environment. Typically, when people come off something like an ACL injury or a lower leg injury, they fear starting to move dynamically again. So starting with things like ladder drills that are controlled, where they know where their feet is going, it's already pre-planned, to then eventually moving towards like what we call open chain agility drills, where they're cutting, reacting, and running, is a nice progression to follow through. But I think this is a huge part of early stage rehab, especially for lower leg injuries like ACLs, ankles, and things like that. Going into strength training, this is obviously where a lot of our time is spent as strength conditioning coaches specifically. There's so much benefit that can come from applying strength training to the people that you work with, right? Aside from strengthening the segment that is injured, the hormonal changes in that happen in the body just from training away from the site of injury are huge, right? We know when we lift, we get big changes in growth hormone, big changes in testosterone, right? If I have an injured right leg and I'm training my left leg, that growth in hormone, that testosterone is going to help the improvement of strength on the uninjured leg. We also know there's neurological cross-education effects. So again, if I'm just training the uninjured leg, we see strength improvements neurologically on the injured leg. So I'm a big, big proponent of getting into training as soon as possible. We also know that well-dosed strength training reduces inflammatory markers, right? So, what we see is less chronic inflammation. That's going to help them manage their pain and manage their inflammatory profile, even if we're training away from the site of injury. So like I talk about getting back to training as soon as possible, Shai has a shoulder injury on his left shoulder. So as you see, I'm having him actively grip with his left hand as hard as possible. He can't do anything dynamic on that side, but simply by gripping, he's getting rotator cuff activation on that side while he's actively rowing on the other side. Now, eventually, this will progress to a more dynamic progression where he's going to start to maybe do some dynamic rowing in the left. But in early stage rehab, if someone has shoulder injury, I usually just start with gripping work like this. That's going to increase the amount of activation of all those muscles around the shoulder for him, because then we can start to build strength without the active movement that might irritate that injury. Tissue resiliency. Matt had been dealing with, some knee issues, and basically just goblet squatting. We progressed from body weight squat to a goblet squat just to start to rebuild that patellar tendon strength there, right? And often, like we're going to talk about later, the secrets to good rehab are just basic progressive resistance, and that's what we're doing in strength training. We are building tissue resiliency. Again, like I mentioned, hormonal profile. The heavier you can get people to lift consistently, you're going to see huge jumps in growth hormone and huge jumps in testosterone. So we want to make sure continually get them in the weight room as soon as possible, because we're changing the internal environment within their body that's going to promote healing. And then joint stability. This is specifically important for things like lower body injury rehab, including things that exercises that require multiplanar stability, things like split squats, single leg deadlifts, especially with things like knee and hip injuries, are going to be hugely valuable, mainly just because of the fact that, you know, we have to teach their body to work as a dynamic system, managing those joints in space. And then finally, stress management. Often, like I said, the rehabilitation process is stressful, especially for athletes and clients who have a lot of things kind of riding on their rehab, people who are worried about getting back in time for a season. We all know that exercise is a very effective stress management technique. So typically, if we can get them in there to train, even if we're not training that injured segment, we're going to help them get through that stressful period of rehab simply because we're giving this to them as a stress outlet. So I don't think that can be underrated, because a lot of times, if anyone in this webinar has gone through a rehabilitation process, there's usually a lot of stress and anxiety that goes along with that. So we're not just thinking about the physical changes, but the psychological changes we can provide them through exercise. Okay. Aerobic development. Obviously, we want to improve, you know, whatever task-specific conditioning they need for their sport. If we're working with an athlete, we want to make sure we start to redevelop those energy systems so that when they go back to the sport, not only will they perform well, but they're less likely to fatigue and get re-injured. We also want to think about the blood flow and oxygenation. Again, in early stages of rehab, we might not be thinking about game-specific conditioning, but simply getting them to do, you know, maybe ride the bike or do some low-level aerobic conditioning helps blood flow, helps oxygen delivery, and that's going to help them manage pain. And then also the local muscular endurance. Again, the people who are more fit typically see less non-contact injuries than people who are less fit, right? Typically, we know that as we get fatigued throughout a game, our motor control reduces and we're more likely to have an injury. So locally improving muscle endurance around the injury site in the later stages of rehab is going to be very important. Okay, so, you know, for a lot of our athletes, that means running things like shuttles, running things like tempos once they're able to start to return to that. Maybe early on, that means riding a bike like this, okay? Just so we can just start to get blood flow all the way throughout the body. Typically, early stages of a hamstring strain, ACL injury, and once they're able to have normative ranges of motion, I'll get them on an Aerodyne bike, something like that, to just start to get blood flow throughout the body, because it's going to promote an internal healing environment for that client. And then finally, and this might be the biggest thing that gets overlooked, like I said, is the psychological management of that client. Often they come into the rehab process feeling a threat. They're feeling anxiety and isolation around that injury. And it's our job to help reduce that threat and increase dopamine. We know that strength training improves dopamine release. We know that it reduces stress and anxiety. So being able to introduce them to exercise is going to help us manage that. And I'm going back to this graphic that I like to use, and it's important to realize, like, coming in, often that athlete is consumed by their injury. That's all they're thinking about, and the injury is the focus point of the training session and the primary talking point, and they don't even think about training and everything else. How often has an athlete told you, oh, you know, I have to be in a cast in 8 weeks, so I can't work out? Like, no, they have 3 other limbs and a torso that they can exercise, and a heart and all these muscles that they can still train, and it's going to help the process. And we want them to open their eyes to that. So I would say we want to flip the image on its head and think about the total development of that individual as the main focus of every session. And that one component of rehab is just a part of it. Because when you flip it, it empowers the athlete to realize that they're not completely incapacitated. They can typically develop themselves much more so than they realize. And it's important to realize that most of our athletes have what I call a negativity bias. Everybody has a negativity bias, right? And it's because with a negative experience, we have stress, we react to it, we lock that in our memory, and then it heightens our sensitivity to it so we can react in the future. So our athletes, you know, they tend to be overly focused on whatever negative thing they're dealing with. And in this instance, it's an injury. Whereas the positive experiences in those sessions tend to pass right through. So I try to draw as much attention to the positive, think glass half full, you know, look for the silver lining in every training experience that we can. Hey, I was telling my athlete, this is an opportunity to focus on developing all these other qualities, right? Maybe your knee is injured, but we can think about improving your aerobic health. We can think about improving your upper body strength. This is an opportunity, not necessarily a setback. And you have to continually open their eyes to that so that they stay motivated to train, they stay motivated to come back and be better than they were before. So because we want to avoid them getting stuck in this, what I call this fear and avoidance cycle, right? And this is very, very common when you see people with pain, especially people with chronic pain. You might think of some of your general population clients who have long-standing issues with back pain or neck pain or something. You very often see this, whereas they have an injury, they have pain, and then they start to, look at it as a catastrophe. They feel all those negative effects. They read about it. They read on the internet about all the issues they can have. They get more anxiety. They get scared to exercise. Then they get out of shape and their pain tends to get worse. So if you look at on the left side of the screen there, they get stuck in that cycle over and over because they're scared to exercise. Our job as a trainer and as the physical therapists, we need to break that cycle. When they feel pain, we don't want to scare them and increase their anxiety, right? So I try to avoid being like, saying things like, oh, you're broken, or you're really screwed up, or you have all these injuries. We don't want to make them feel worse. We want to reduce their amount of fear. We want to clear up any confusion they have and then empower them to start to train, right? And that's going to be their way out of that cycle. But if we let them get caught in this anxiety cycle where they avoid exercise, they tend to get weaker. They tend to see higher levels of depression and anxiety, and we see their amount of disability tend to go up. So we want to try to steer them the other direction and break that cycle as much as possible. There's a great book by Chip and Dan Heath called The Power of Moments, and they talk about why certain experiences have extraordinary impact on people and how you can change people's life in an instant based on certain experiences. And they have 4 major key things that they find fuel very powerful moments in people's lives where they turn their life around or had a big change or like had a big breakout moment. And these are the things you want to try to highlight for your clients in the rehabilitation process from a psychological standpoint to motivate them. They talk about, number 1, you want to look for moments that elevate, moments that provide an emotional peak, right? They position clients, how can we provide a peak for them that motivates them? And so one thing I was thinking about is positioning my clients for success early on and celebrate every single win. I think, I would rather start with someone doing something that's too easy in the gym so they feel like, oh, I can do this, and they feel confident and they get that hit of dopamine, and that motivates them to go forward, as opposed to having them struggle at the very beginning. Sometimes that can demotivate people. So look for things that provide an emotional peak and show them that they can be successful. Number 2, moments that provide insight, moments that rewire our understanding. So create teachable moments regarding pain and tissue damage. For instance, when a client comes in and says, oh, my back is wrecked, they have chronic back pain, they say my back's a disaster, I'll say, pain is just an experience that you're going through. You're not a disaster. There's many other qualities we can improve, and you're going to see that your back improves with that. Getting them to kind of open their mind up away from just that injury, starting to educate them a little bit about pain science and understanding that, there's a bigger picture outside of this. Pride, capturing them at their best. Try to recognize and create rewards for successful behavior change. Sometimes I have people dealing with chronic pain. One of the biggest issues that they have is their sleep, their nutrition, and their stress management. So sometimes I'll, create a reward system and say, okay, if you can, sleep for, average 8 hours of sleep this whole week, maybe I provide some sort of reward, right? There's an external motivating factor for them, and recognize that. You have to try to, put a carrot out there for them to chase. And then finally, connection, moments that are provided by social connection. Encourage and support participation in social events, whether that means social gatherings at the gym, whether that's encouraging them to take part in some sort of club or sports team or activity that they couldn't do before due to their injury. The more they have social connection, studies tend to show people come out of these rehab processes much better than when they don't. So look to try to include these, elevating moments, insight moments, pride moments, and connection moments within the training program. And realize, again, as fitness professionals, we're guiding people. We're not providing a plan. We're not offering a cure. We're providing a plan. We're trying to, show them what they can do. We're not becoming over-reliant on their diagnosis. We're trying to explain to them that their pain that they're dealing with is, multifactorial, in that we want to try to educate them in this process. Often clients come into you and say, oh, my MRI said I have 5 bulging discs and I have this, this, and this. And them just continually think about that can actually make their pain worse. Whereas if we can take the time to educate them that they're not, their MRI isn't everything that they're dealing with. There's things outside of that we can improve to make their pain better, right? We don't want to promote movement avoidance. Often people are saying, oh, my doctor said I can't squat. My doctor said I can't do push-ups. My doctor said I can't do this. We want to focus on what they can do, not the things they can't do. So we'll say, okay, maybe you can't squat right now, but maybe we can do a sled push, or maybe we can do a hip bridge. Let's focus on developing those things until we can get back to the other things. We have to open up their eyes to what they are able to do, because like we said before, they typically have a negativity bias. And I always say, I don't want them to feel dependent on me. I want them to feel like they are empowered to fix themselves. Often, you get clients who say like, oh, like if I don't see my physical therapist or my chiropractor every week, my back will be a mess. I don't want them to feel that way about me. I want them to think, they could exercise on their own. So we want to think about educating them and coaching them, not having them be dependent upon us. And again, all of these things are going to promote them to heal quicker. Generally, when we look at pain science, when clients are empowered and feel like they have autonomy, they tend to come out of these rehab situations much better than when they went in. Now, from there, where do we start? How do we do an assessment? Where do we start progressing from there? So going into here, number one, try to avoid detraining as much as possible. When you look at all the research regarding injury risk, especially in sports, when the risk is the highest, it's when you see a peak in activity followed by a big drop off followed by another peak. So right now, a good example with the COVID-19 situation, you have a bunch of athletes who have not been exercising, not been doing anything, and they're going to go right back to their sport. And I think we're going to see a whole bunch of injuries, right? That is what we're trying to avoid. We want to keep the level activity chronically high. So when I have an athlete who is injured, okay, I try to get them back in the gym as soon as I can after they've seen a doctor and seen a physical therapist, and get them their fitness back going again. Because typically when you see a huge drop off, you see tendons weaken, you see muscles weaken, you see aerobic systems weaken. And then when we try to go right back into training where we were before, that's usually when people get hurt. So we want to get back training as quickly as possible. Okay. From there, when they first come, we need to do a needs evaluation. We need to look at, what might have detrained while they were gone, what might have been something we overlooked that got them injured in the first place. So I want to go through things I would call red and yellow flags. I want to look at their fitness and their training levels. And then all the way on the right in the green here, I want to look at their stress and their lifestyle habits as well. Realize, again, what we're dealing with in rehab isn't just physical. I think often as strength and conditioning coaches and physical therapists, we become so focused on the biological and the physical component of this. We improve strength, we improve motor control, we improve mobility, we improve aerobic health, we improve all these things that are like right in our wheelhouse, right? But that's only 1/3 of the entire rehab process. When you look at the pain science, it's very clear that the psychological aspect and the social aspect have an equal amount of effect on people's pain and rehab outcomes. How do we manage their emotions and their attitudes? How do we manage their anxiety and their depression? Talk to them about their injury history and their past diagnosis. How are their friends and family and relationships helping support their rehab, right? We want to see that they feel like they're supported by not only you, not only by the doctor, but then the people that are immediately surrounding them. So sometimes with my athletes, especially my kids, part of the rehab process is me also talking to the parents about what I need them to do, how they can support them, because it's going to change their long-term pain outcomes. Number one, if you don't have a standard intake that your clients fill out every time they come to you, then you're not getting the job done from day one. You want to make sure that they fill out not just the basic information like their name and all these types of things, but getting all of their injury history, all of their background, and letting them take the time to fill this out. And I might let my client write this for like 30 minutes, write a full description of all your past injuries. Because if you don't know what their history is, then it's going to be very hard to plan for their future. You need to know where your clients are coming from. So take the time. This will help us figure out any red flags. What medication are they on? What is their stress level? How would they describe their pain? What is their injury history? All of these things are going to help form an image of that client in our head. We know if they have like 10 different injuries in their injury history, it's going to be harder to rehab them because of all of that trauma that they've been through. They're going to be a little bit more anxious around the situation, right? Where someone with very little injury history might be a little bit easier to deal with. Okay. Also, if we know if they're on a number of medications, if we can see, if they describe their pain as a 10 out of 10, we know, okay, maybe we have to start further back on the spectrum. But getting all this stuff out consistently on paper makes your job much easier as a fitness professional. Okay. Being able to take a look at 2 different clients here, for instance, both of these clients are people who I have worked with, who I've rehabbed. Okay. Both dealing with knee pain, but how I deal with them would be completely different based on their objective information on their intake sheet. Okay. If you look at this client on the left, 18-year-old female soccer player, ACL tear. She had an MRI, she had surgery, and entered physical therapy. Hurts when running, and the pain is sharp. There's a very acute injury. We can put our finger on when it happened. Very low injury history, and currently going through rehab, right? Pretty cut and dry. Now, similar type of knee pain on the right, but not from an acute injury. 35-year-old male, chronic knee pain, played a lot of sports when he was younger. Imaging and diagnosis was inconclusive. They saw cartilage degeneration, didn't have surgery, did some physical therapy for 4 weeks, wasn't helpful. And the way that he describes his pain is achy, it hurts with stairs and too much activity. 2 very different knee pain situations, right? So how I'm going to deal with them is going to be much, much different. That 18-year-old female soccer player post-surgery, I'm going to have to be very regressed and cautious with, because I know that ACL graft needs to heal, right? And I'm just going to use progressive resistance starting very, very regressed. It's probably not a mobility issue. It's solely probably a stability issue. It's an 18-year-old female. Now you're talking about a 35-year-old male that has a lot of mileage behind him. I'm going to be able to probably start a little bit more aggressively, but I have to probably invest more time in mobility. I probably have to invest more time in improving joint and, how his joints move. But without all of this basic stuff on the intake, sometimes they just come in complaining of knee pain. Okay, so you need to be able to take the time to put all these things down on paper. Realize, again, this guy that I just talked about, with that girl versus that girl I just talked about, a lot of her pain is going to be directly related to inflammation, scarring, and remodeling directly in that pain in that tissue, because she just had an ACL injury and she just had ACL surgery. Whereas this is a guy, the 35-year-old guy here on the right, he's had pain for years in his knees. You're going to realize that less and less of that pain is going to be directly associated to the tissues, and more because he's just been in chronic pain. So what we need to do with him is typically just get him active and get him moving. Whereas with her, we need to really pay attention to the inflammation, the scarring, the remodeling that's going on in those specific tissues. Asking the questions too when they have pain. What causes pain? What were you doing? Is it worse in the morning? Is it better or worse with or without activity? What feels good? What feels bad? All of these things are going to guide us in our exercise selection, right? If someone has pain doing everything all the time, we're going to have to start very regressed. If someone only has pain doing one specific activity, we can be much more aggressive. And this might seem like common sense, but consistently asking these questions is going to help you make better choices as a strength and conditioning coach, as a personal trainer. Then we want to start to think about, how do we assess, how do we understand where they can start, right? If someone comes in with back pain, are you going to have them deadlift and hang clean on day one? Or are you going to start with bridging? How do you make those decisions? Because the answer could be either, depending on how you assess that client. So we want to make sure that we have a system for doing that. And I personally like using the SFMA, the Selective Functional Movement Assessment. It's through the FMS. You might have another system, and that's perfectly fine. But I think you need to have a standard system that you use to be able to assess every client that comes in through the door. Okay. So if we want to make it really basic, and I'm going to break down the SFMA as simple as possible. This is not a replacement for the SFMA in any way, shape, or form. I'm just going to kind of show you as a trainer, what process can you go through. I think number one, you have to ask them, the classic Mike Boyle question: does it hurt? So let's just say this person came in with back pain. Okay, does it hurt? Yes, I have pain. Okay, if they're not already seeing a physical therapist or a doctor, refer them to go get that managed by a medical professional. That doesn't mean that we can't train them. We can still train them, right? But we still want to make sure they're seeing a PT. If they say no, can they do some sort of movement, right? And then we're going to break it down and see, can they do it unilaterally? Can they do it unloaded? And can they move them independently? And I'm going to add some pictures to this now so you can understand it, right? So say that person came in with back pain and I asked them to bend over and touch their toes. And they say, okay, I have pain when I do that. We're not going to do any activities that are going to require them to do that until they can do that pattern. So if you look at Gray Cook there, touching his toes at the top, that would look a lot like deadlifting. So I'll probably avoid deadlifting. I'll probably avoid swings. Okay. That would still let us do bridging. That would still allow us to squat. We could start to train all those patterns. Say he comes in and that doesn't hurt, but he does have it. We are rehabbing back pain. It just doesn't hurt when he flexes. Then I want to see, okay, can he do it on one leg? Then I want to see, can he do it sitting down? Can he do a leg raise? Can I do an assisted leg raise? And it's going to help us choose the select exercises, right? So if he can't do a one leg bend, I'm going to look at him doing it seated, or I'm going to look at him doing a leg raise. Whereas if he can, that means I can single leg deadlift. Or if he can do a bilateral bend, it means he can bilateral deadlift. We have to have a standard selection process to be able to make the right choices, to select the right exercise, to make sure we're not putting clients in harm's way, and to make sure that they're going to be in the optimal, choosing the optimal exercise for their rehab. And the SFMA does that for clients, and it does it for physical therapists, and it also can do it for trainers, because we're just going to look at everything loaded, unloaded, unilateral, and bilateral. And that's going to help us make best choices for exercise. From there, we want to start to zoom in and look closer at their joints. And I think you need to be comfortable as a trainer putting someone through a general orthopedic assessment on the table, looking at their shoulder, looking at their hip, looking at their back, to see if they have adequate joint range of motion. Okay. Are you comfortable looking at someone's toe extension? Are you comfortable evaluating someone's ankle dorsiflexion? All of these different joint range of motion, hip abduction, hip rotation, so on and so forth. If you're not comfortable looking at someone's passive ranges of motion, like a basic orthopedic assessment, then you should learn how to do that. Because again, if someone comes in with knee pain, they're only complaining of knee pain, and then you assess their ankle dorsiflexion, and their ankle dorsiflexion is limited, that's something that we can improve that will directly improve their knee pain, right? Typically, people who have chronic knee pain during running have limited amounts of ankle dorsiflexion, right? If someone comes in and they're complaining of back pain, and you assess and see that their hip rotation is limited, or their hip flexion is limited, that's something you can work on as a trainer. But you can't work on it if you don't know what the issue is. So develop the skills to be able to look at these things so that you can go ahead and fix them and start to identify blind spots in that person's movement skills. Because typically wherever the pain site is not where the pain source is. And as a trainer, your specialty is going to be improving all of those things away from the injured segment. And then finally, zooming in a little bit closer, what are their capacity levels? What are the things that we work on at MBSC and CFSC, and from a nutrition and lifestyle management, things I've learned through precision nutrition to help them get better? You know, where does fitness fit into your life? Typically, I always ask this question when people come in, you know, what does your normal fitness routine look like? So say if I have someone coming off the street and they're complaining of back pain, I'll ask them, like, before you start working with me, what is your normal exercise routine? And lots of times, like, this is someone who I actually saw last, like right before we closed up here. And I said, you know, why do you have back pain? And they're like, I don't know. I'm like, well, tell me about your exercise routine. And they said, you know, I do bar class 5 days a week. I run 3 days a week. I do yoga 4 days a week. Like, they're doing multiple exercise sessions every single day. And I said to them, before you start paying me to work on you, why don't we just look at your exercise routine? Because I think you're probably just doing too much. And very often you'll find that you can improve people's pain and their chronic pain issues simply by just managing their training program, because it's ineffective programming, right? So sometimes it's not necessarily a mechanical issue as much as it's a workload issue. And you have to be able to ask that question first and foremost, because sometimes we miss that if we think that it's just a mechanical issue, if we're not thinking about how their overall training program looks. Also, I want to take them through what I call a basic movement checklist. And on my first day with this person, after I do a movement assessment like an SFMA, I typically will take them through, what I call like my basic entry level training routine. I want to see their squat. I want to see them hinge. I want to see them do a single leg hinge. I want to see them move in the frontal plane doing a lateral squat. I want to see some single leg movements like a split squat or a single leg squat. I want to see them push, pull, plank, and carry, jump, throw, skip, and do some sort of drill like a ladder. This is going to give me a really good idea of their general strength and movement quality. And these things will not be loaded heavy. They might be body weight, but you can look at someone in a basic exercise and tell, they have a limitation in their ability to hinge. They are not that strong through their core because they can't do a plank, or they're unable to jump and land effectively. Maybe that's why they're dealing with chronic knee pain when they run. Okay, so have a basic entry-level training routine. And that's what I always do with my new rehab and new pain clients, is take them through a training program that looks something like this. Might only do 1 or 2 sets of everything, but it's going to tell me where they have something that they need to work on. And I'll pretty much always do this, and it's extremely valuable to my process. Additionally, I think you also have to look at their aerobic health, and don't just look at what they're doing in the weight room. So, I might ask them, a lot of people have iPhones, or heart rate monitors, or those Apple Watches. And I'll say, hey, can you wake up and tell me what your resting heart rate is in the morning? Because typically if someone's waking up with their heart rate out chronically above 60, there's either an aerobic health issue or there's a stress issue, both of which are going to affect their daily pain. So that might be something we need to look at. I might put them through a modified Cooper's test on the Airdyne bike, maybe not the first time they come in, maybe the second time, just to get an idea again of their aerobic health. 6-minute time trial, have them go as far as they can. I'll record their heart rate throughout, and I'll see how quickly their heart rate drops in the minute following. That's going to tell me, how fit they are. And then in the later stages of rehab, whether it's an athlete or a general population client, I'm going to want to do aerobic work that's specific to the demands they're going to have in their sport or their occupation. So maybe for soccer players, we have to develop the aerobic system and their sprinting ability for them to play soccer. Maybe for someone who does manual labor, we have to, develop their aerobic system to support that. But that'll be in the later stages of rehabilitation. Like I said, on a modified Cooper's test, I'd put them on the bike like I showed in this video earlier and record their heart rate and see what happens. You need to be able to assess to see where they're at to make these decisions most effectively. Going and talking about lifestyle, again, the questions I tend to ask everyone: how many hours do you average sleeping every night? You'd be surprised about how badly a lot of your clients sleep. And so again, if someone's dealing with chronic back pain or chronic neck pain, and they're only sleeping 4 hours a night, they don't have a shot to get better. And you could do all the right things in the gym, you could do all the right things in the therapy room, but if they're not sleeping, they're not recovering, they're not managing their stress, they're not going to get better. So sometimes, again, what the conversations we need to have as fitness professionals are outside of what we do in the gym. It's about helping them manage your sleep. Okay, what can we do to get your sleep better? Get you away from your iPhone, get you off the computer, get you out away from being in front of the TV right before you go to bed. Set a timer. Say you have to be in bed by 9:30 and you have to sleep till 5. That can be hard for people because they have to change their normal routines. But usually their routines are what got them injured in the first place. So we need to sometimes have those conversations. Nutrition. Do they eat like an adult? Like, if someone's dealing with chronic pain and I can observe and see that obesity or being overweight is part of the issue, I might have them start to food log. And I've had clients say to me, like, I'm here for, chronic back pain. Why are you having me look at my nutrition? And I'll say to them, well, you are built out of the things that you put into your mouth. So the quality of nutrition that you put into you is a resulting in, the type of quality of fuel that you have. So if we're not looking at these things, then again, I don't think we're giving them a shot. And then finally, I'll ask them to take me through their entire day. What time do you get up in the morning? What's your morning like? What's your day at work like? Do you have any leisure time? Do you have time at night to relax? And I'll say, rate your day from 1 to 10 on how stressful it is. And if that number is too high, we have to find ways to get that down. Again, we know with people who are dealing with chronic pain that high levels of stress and anxiety affect their pain sensation. So again, we want to try to get those things down. And these things can be difficult to have conversations with clients about because often when they come to you, they don't think these things are related to their pain. They often think all of their pain is mechanical. But often with our clients, we need to talk to them about how can we manage all these other things to help manage their stress. I'm going to skip through here to programming, just because that's the same slide. And then from there, when we build a program, after we assess all of these things, after we look at their movement quality, after we look at their strength, their aerobic health, their stress, their lifestyle, we want to try to build a program based on if they were healthy. So let's just say we had a competitive soccer player who is 18 years old. Before I start to factor in all their limitations, I would write a program for a healthy 18-year-old soccer player first, right? I would imagine that person was completely healthy and they wanted to improve their performance. I would write that program. Then I would take into account all of the limitations that I saw in their assessment. Maybe they're limiting ankle mobility. Maybe they have pain when they do knee dominant exercises because they came in for a knee pain. And then I would go in and I would adjust the exercises accordingly. The reason I do this is because if you write the program for somebody who is healthy and then you simply subtract the things that they cannot do, the program is going to be much more aggressive and much more suited to getting them better quicker than if you write a program for someone who is injured. This is almost always the case. So I always tell my clients, my coaches rather, start with the end in mind. Write a program for someone who is healthy, and then simply just subtract and substitute for the things that they cannot do because of the injury. And they're typically going to be much better off than if you do it the other way around. And although this might seem counterintuitive, I promise you, this is going to empower the client to realize that they can train, that they're not limited to only doing rehab type exercises, and that you can train them aggressively. And so what I want to do when I do that is we're essentially just creating buckets of things that are trainable and non-trainable, right? Here, the only things that are non-trainable are the things that are circled in red. Look at all the other things that this client can do really well with this injury that they're dealing with, right? Put as much stuff into the trainable bucket as possible. And then we're just going to work on slowly taking things in that non-trainable bucket and moving them over to the trainable bucket. You know, maybe 1 week at a time, 1 month at a time, however long it takes. And so then how do we go about doing that? How do we progress once we have a program built and we've assessed the client, we've started to assess what we need to do? How do we move them along most effectively so we don't have setbacks, but we also get them back to their sport or back to their daily life as quick as we possibly can? Again, like I said at the very beginning, don't forget about our principles. The same things that make a great training program for someone who is healthy are the same things that make a great training program for someone who is injured. We might just need to start a little further back on the spectrum for that client to get them to where we need to go. So progression, we're always going to move from things that are unloaded to things that are loaded. We're always going to go from moving slow to moving fast. We're going to move from supported to unsupported. We're going to go from low volume to high volume, low frequency to high frequency, and full recovery in between exercises to partial recovery in between exercises. We're always progressing in that direction. Okay. The number one thing we can start to progress is positions and areas of support, right? So what we want to do is work from position of the most support to a position of the least support, right? So I have two different examples here, moving from seated all the way to single leg here. So if I took someone with an ACL injury on the left side of the screen here, and we're doing a cable chop and lift like we teach in the CFSC course. Maybe for someone with an ACL injury, we have to start seated because they can't do tall kneeling or they can't do half kneeling because of their knee. That's fine. We're going to start seated. They have the most support there. Then maybe we can move to tall kneeling once they can kneel on 2 knees. Then we can move to half kneeling. Then we can move to standing. Then we can move to split. Use our progressions and regressions to move through the developmental progression from the ground up. Maybe you're dealing with someone who has a back injury and we have to work on anti-extension strength, strengthening their abdominals. Maybe that back injury is so bad when they first come see you because they just injured it. Maybe we just work on 90-90 breathing where they're laying on their back completely supported. Maybe that's where they need to start, okay? Then maybe we move to front plank. Then we move to ball rollout. Then that's at tall kneeling. Then we go to half kneeling. We do cable lift again. Then we move to a ring fallout that's standing. Again, this could be right here. a 10 or a 12-week progression in a training program, spending a few weeks at each of these exercises to build resiliency. And my point is, if you have a progression regression sheet, you have a model that is thought out and planned, it makes rehab very easy because you've already thought of how to make things easier and harder. But if you're just kind of making things up as you go, it's a lot harder to try to make the right choices. Same thing with loading, okay? Starting contralateral only, okay? Maybe, again, if I'm coming in with an ACL injury and my right knee is injured, I am going to just start by training the left knee, okay? We know that's going to help the outcome on the right knee after. Then maybe I start with an assisted split squat where I'm holding a TRX or a band. Then maybe I move to unassisted, like a bodyweight split squat, then to loaded. Again, this could be, 12 weeks of training for someone coming right after an ACL surgery, right? So for instance, here's a girl that works with us. She had just got her foot done, and she was in here about a week or two later with the boot on, and we're just training the opposite leg, okay? We're getting in there as soon as we can to start to keep maintaining, developing the power on the offset leg. So that way, when we get to be training on the other leg, we haven't regressed on both sides. Same thing, single leg deadlift reaching, okay? There's no reason post-surgery on her left foot that we can't immediately get in here and start training on the opposite side. Same thing here. These are both examples of upper body injuries for clients. Girl on the right had a wrist injury. The woman also on the woman on the right also had a wrist injury. I have them holding the sandbag in the elbows so that we can get lower body training because they can't grip with their hand. Similarly, when she's bench pressing, I have her holding a push-up handle. There's no weight to that, but she's actively gripping to develop the isometric strength around that wrist until she's able to hold a heavier load there. So again, you can always find ways to load. You just probably need to be creative in how you go about that. And then following our progression, again, if you've taken CFSE, this should be really familiar. That's why we have progression regression sheets. If I have someone come in with an injury, like a knee injury, maybe we have to start with an assisted split squat. They have patellar tendon pain. Maybe we have to do that for a few weeks till we develop a little resiliency, and then we can go to bodyweight split squat. Then from there, we can start to find ways to load the split squat, probably going to goblet, to dumbbell, and then working our way over to rear foot, okay? So we want to think that, there's always a progression that we can work to. You just have to pre-plan these things out to continue to find ways to increase the stress on the target tissue. Again, sometimes coming off an injury, it's best to start with things like isometrics and progress through our contraction types. So you always want to start with slow and move towards fast. So that means starting with isometrics, moving towards eccentric focus, then to regular concentric focus, and then to dynamic, right? So maybe that means in phase one, coming off a knee injury, starting with things like isometric split squat holds, okay? And then going towards an eccentric split squat where they're holding a TRX, they're getting some assistance, then moving to a regular split squat, then moving to our plyometrics. But if they don't have isometric and eccentric and concentric strength, and you just start jumping and hopping and bounding, that person is going to end up regressing and getting hurt. So you want to make sure you follow the contraction types, because isometrics are typically not going to cause an inflammation response, whereas concentric and dynamic actions typically will, because there's rapid change in tissue length. And then we want to think about managing things like frequency and volume. And these are sometimes things that we get overlooked in training programs. If you look at any of our initial training programs, sometimes you'll see clients doing 1 set or 2 sets. And sometimes I've had trainers come in and say, why are you doing so little? But it's because it gives me more room to progress over time. If day one, someone comes in after, a back injury, and we're going to do 1 set of 5 hip hinges or 1 set of 5 deadlifts, but then day 2, they come and do 2 sets of 5, realize that's twice as much. Like, we're increasing the volume by, 100% between the first session and the second session. That's a lot. But so if we can start at 1 set of 5, make sure they feel okay, make sure there's no pain, no setbacks, then go to 2 sets of 5. Then you go next session, you go to 3 sets of 5. Then you go to 3 sets of 6. Then you go to 3 sets of 8. We want to slowly build volume. I would rather start someone further back, very regressed, so that they don't have setbacks, and then it gives us more room to progress them going forward. If you start doing 3 sets of 8 off the bat, typically they're going to be sore if they've been injured and been inactive for a long period of time. And it also gives us less room to progress forward, because how much more volume are you really going to do from there? So I always suggest on day one, make it easy. Show that person they can be successful. Psychologically, that's typically a win for them. And then we can progress from there. And then finally, we want to think about frequency. How do we want to build a program to ensure that we're slowly introducing them to new actions? And this is kind of based around what I typically do with ACLs. So following an ACL surgery, I might see someone 8 to 10 weeks after their surgery, after they've gone through initial physical therapy. I might see them 2 times per week. We're not going to do any knee dominant exercise. We're not going to do any running and impact, and we're just going to do hip dominant. Only 2 days a week, upper body and hip dominant exercise and core exercise. Okay. 3 weeks go by. Maybe we're doing 2 times per week. Still no running and impact, but we might do goblet squat 1 day per week. So 1 bilateral knee dominant exercise for 3 weeks. Now, the rest of it's still hip dominant, core, and upper body. So they're only getting 3 exposures to squatting over the course of 3 weeks. Pretty low frequency. But then the next 3 weeks, we're still training twice per week. Now they're going to goblet squat once per week and do split squat once per week. They might do some low-level plyos, and they might run 1 day and still do a bike 1 day. So we've increased the frequency of knee dominant exercise for this ACL injury. Okay, but at this point, we're 4 to 6 weeks into exercise before we even start doing that. Then the next 3 weeks, at week 17, we increase the knee dominant frequency a little bit more, right? We're still going 2 days per week, but we're, in addition to goblet squat and split squat, we're doing single leg squat. We increased 1 more day of plyos, and we increased 1 more day of running. Let them normalize and do that for 3 weeks. So as you can see, we're slowly adding 1 more variable in, letting them stabilize and get used to that variable for 3 weeks. And then we're increasing and adding another one. Now by week 20, we can train 4 days a week. We're doing plyos and running twice a week. And now 20 weeks later, we've made huge progress. But if you try to start, at week 14, if you try to start doing knee dominant right off the bat, you're typically going to see a setback, and then you're going to be behind. So I always err on the side of caution and limit the amount of frequency and exposures, make sure that client is responding well, let them normalize and get comfortable doing that for a few weeks at a time, and then add another exposure. We want to slowly increase the frequency to whatever that stimulus is to that injured segment that is going to get them better. So over time, slowly feed in more exercises. Okay. In summary, kind of going through this, because I know we have some questions we got to get into in the next 15 minutes, is number 1, join and build a team. If you're going to be doing rehab, go out of your way to find other professionals who align with how you think about doing things. That means seek orthopedic surgeons and doctors who believe in what you do as a fitness professional, and find orthopedic surgeons and doctors who you believe in what they do, because they're going to refer clients to you and you can refer clients to them. It's going to be a very good situation. Find physical therapists that you believe in. Find sporting teams who you can work with. Then it creates the best environment for clients when you do have them. Number 1, know your role. If you try to be a physical therapist, you're going to be a bad physical therapist. Just like if a physical therapist tried to be a trainer, they might not be a great trainer. You want to be able to be who you are and understand when it's your role to participate. Number 3, no pain. We don't want people training in pain. We want to find pain-free entry points to training. That's what this whole assessment piece was about. How can we find areas for them to start training and then build resiliency from there so we don't have continued pain? And then number 4, don't forget your training principles. We'll go from slow to fast, unloaded to loaded, low frequency to high frequency, low volume to high volume. And over time, if we're starting in the right place and we're taking slow, methodical progression, we're going to get them to where we need them to be. Okay. There's my contact information if you need to get a hold of me. If you haven't been through CFSC course, we will be back in Brazil later on this year, and I hope to see you all there. So hopefully we can answer some questions now.
Very good, Kevin. Very good. I think we have a few questions here. Let me see. This is from Felipe from Rio. Mm-hmm. Do you use foam roller at the lumbar spine?
Yeah, absolutely. I think that, The times I've heard people not to say not to foam roll the lumbar, it's typically because they think you're going to cause some sort of instability, right? And it might contribute to the instability they already have. But it's important to realize the foam roller is not such a powerful tool that's going to get all your core stabilizers to just shut off. What a foam roller does is just reduces the chronic tone, especially in those lumbar erectors where a lot of people are suffering from chronic stiffness and back pain in the first place, right? It's giving us a limited window of opportunity to start to normalize the range of motion there and start to reteach them how to move their lumbar. So I don't want it to be particularly painful, but I'll have them roll their lumbar. And the only time I'm cautious with lumbar foam rolling is with elderly individuals who might have osteoporosis, because if you press too hard on those spinous processes, you can get stress fractures. So that would be the only time I might be cautious with that. But generally, yes, I will foam roll the lumbar spine.
Good. Which kind of strategies, assessment strategies, do you recommend?
Like I said in the presentation, I really recommend the SFMA. And I know they market it and sell it to medical professionals like PTs and chiropractors and doctors. But it's important to understand, as a fitness professional, strength and conditioning coach, you are able to take that course. They allow you to take that course because they're not teaching you how to treat pain. They're teaching you how to assess movement. It's really just an expanded version of the FMS to say, okay, can someone touch their toes? Okay, if they can't touch their toes, can they flex their hip? If they can't flex their hip, can you flex their hip? So it takes you through a progression to look at things, loaded, unloaded, passive, and active. And that is basic assessment skills that a physical therapist should have, but also a strength conditioning coach should have. So highly recommend their assessment process.
Very good. Do you believe that we can use the hurdles in a higher level to train people? Because is Felipe again, he believes that we can change the patterns, the movement patterns. I would like to hear you talk a little bit about this. Do you understand the question? Sorry if I...
You mean like jumping over high hurdles?
Yes.
Yeah, I mean, when we select our hurdle heights, typically at the gym, we select it based on one, can they jump that high? But two, can they land well? So I'm only going to have them jump as high as they show me they can jump properly over the top of it. And then can they properly land? I don't want them jumping over something that's going to affect how they jump, and it's going to affect their quality of landing. So the number one thing, their form in both of these situations has to be number one.
Very good. And how about people that when they jump hurdles, think about high hurdles, they flex or bend too much the knees and they don't show a good patterns? Do you have some advice for this situation?
Yeah. Well, so the number one thing I want to see is when they jump that they get triple extension through their ankles, through their knees, through their hips. Okay. If they get that, if they bring their legs up after, I don't mind. I just want to see that when they jump, they get that extension first. After that, I'm okay with them bringing their legs up so long as they get everything extended before that.
Perfect. Can we consider that the psychology factor is the greatest challenge in treating an injury?
Yeah, I would say it is the greatest challenge because the pain science research is fairly clear that if you could do everything right from a physical standpoint. You could normalize their range of motion. You could get them stronger in their core and in their hips. But if you don't deal with the psychological aspect, that person can still have pain. Where we know a lot of you have probably worked with clients who you look at them move, they move well, their MRIs looks good, but they still have pain. And typically it's because of the psychological issues. So being able to work with that, and it can be very difficult because we might not always have the answers, but we want to be as supportive as possible to those clients. We want to help them work through any of those limitations they have. And it can definitely be the most challenging part of the rehab process.
Good. One question here I think is very easy to answer. Do you apply mobility exercise at the move prep? We do. It's a part of the process, right? We
Yes,
don't
always. Yep.
skip this. Maybe
Yes.
this person is not a CFSC certified yet, so it's not so clear yet. From Guy, hi Kevin, thanks for this presentation. Sometimes we have some amateurs athletes and we see some with a degree of chondromalacia. How we can manage a training while they play their sports during our rehab program, managing the injury in season.
Yep. So then that can be difficult because there's obviously a lot of volume of running and things like that in season. So we want to think, what are the things that we can control? If we can't control the amount that they're playing, if we can't control the amount of minutes they're playing their game and the amount of games they play, then we have to think about everything else. So managing mobility at the surrounding joints, chondromalacia, the knee, we want to think about improving quad flexibility, hip flexibility, ankle flexibility. Those are going to be the things that are going to affect the amount of stress that go through that joint. So improving the mobility there, consistently exposing them to that mobility work, thinking about reactive pain management strategies. So are they icing after games, things like that. And then just maintaining a certain level of strength in the hips. So lots of hip dominant training, typically with people that are dealing with chondromalacia, because it's not going to add stress to the knee, but it is going to help the stability of the knee.
Good. Vinicius is asking about how's the importance of foam roller on the beginning of the training and not at the end of the training, because he sees some people having this discussion and he would like to see you giving your feedback, your advice.
Ideally, I like it when they do both. So, I mean, I always do it before because I think it just gives us a window of opportunity to move better in that training session. But if they're able to have time to foam roll after as almost like a cool down or on their days, even when they're not seeing us to train, I think that that's ideal. It's never going to make them worse, right? It typically is going to make most people feel better. So if we can invest more time in that, I think it's good.
Good. Two more here. About stretching, there is too much controversy and too much discussion about this. What is your position on this situation, stretching or do not stretch?
I think the reason there's controversy around stretching is how people stretch. And I also think a lot of the research surrounding stretching is very poor. So a lot of the things that started people to say don't stretch are these two research studies. One that showed a reduction in power after people were stretching. And it's important to realize how they went about making that study. They measured people's vertical jump. They had them stretch their hamstring, and then they immediately measured their vertical jump again. I would guarantee you that would make someone's power output go down. But it's important to realize that that is statistically significant in the study, but practically insignificant in how we actually train people, because that's not how we stretch in a training program. When we stretch, we do our stretching, then we do our warm up, and we do all this stuff before we do any power training. It negates the reduction of length tension relationship that happens in that study. It's not how we stretch. Also, the benefits of stretching typically outweigh the reductions of power in that training program. The reductions in vertical jump in that study were something like 1%, which is statistically significant. But that doesn't really make a difference in our training program. Also, the other studies that showed stretching was ineffective, they did stretching for like 15 seconds. And then they measured, what was the injury risk in the season. The problem is that stretching alone isn't going to reduce injuries. Stretching is part of the overall recipe to make someone more injury resistant and resilient. And they also have to strength train. They have to do motor control work. They have to do conditioning. The way to stretch is look at all the joints that tend to get stiff in the joint by joint, whether that's the ankle, the hip, the thoracic spine, the shoulder. Spend a minute in each position actively stretching them into positions, and then follow that with motor control work and strength training. That's how you improve movement quality. So I think we always get caught up on one ingredient in the recipe, like should I stretch or should I not stretch? None of these things are really valuable in and of themselves. They're all valuable together in the formula that we are providing in the training program.
Good. I'm trying to be fast here because I don't want to cause some problems in your agenda. I have 4 more minutes, right?
Mm-hmm.
How do you manage this psychology pain? How do you work with people that, in your opinion, you identify that is a psychology pain?
So I'll try to talk through. I look for things that are red flags and yellow flags, as I would say, with their pain. So, one, do they have a long injury history? Okay, how can we start to talk to them about the fact that because they had a bunch of injuries, that doesn't mean they have to be broken and destined to be in pain for life. If there's someone who has anxiety or stress issues, I'll talk to them about ways we can manage their stress and manage their anxiety, whether that's meditation or diaphragmatic breathing or managing their sleep. Like I'll try to talk. Some of our training sessions, I had someone with back pain. We just meditated for a couple sessions so they could manage their stress. Then we went back to training because their stress was so bad. Maybe it's getting them to reframe what's going on. Lots of times they have this idea that they have bone on bone in their knee, right? And I'll explain to them, you don't actually have bone on bone. Sometimes just getting them to understand their diagnosis better can help their pain sensation. So it really starts with having conversations, identifying false beliefs, and making them feel empowered that they can get better in this situation, that they're not helpless.
Good. Last one here. You said for the rehabilitation, it's very important to begin with the isometric component, isometric training.
Mm-hmm.
This is the same advice for rehabilitation, muscles rehabilitation, or just for joints rehabilitation?
Generally, most tissues are going to be favorable to start with things like isometrics or slow movements because there's going to be less change in tissue length, which causes less of an inflammatory response. So, I mean, if there's something like, for instance, if someone has a hamstring strain or someone has a patella tendonitis issue, both of those are going to respond well to isometric work first before doing things that are going to change the length of the tissue.
Very good. And we will have Scott talking about this for the next webinar. Scott
Oh, awesome.
will be very good on this. So we have other questions here, but I will send for you because I don't want to cause some delay in your agenda. Don't turn off before sending me the host. I need to be the host again. Let me see here. How can I
think I can do that, right?
Yeah.
I can make host. I gotcha.